A macular hole is a full thickness defect in the foveal retina from internal limiting membrane to the outer segment of photoreceptor layer. The first macular hole was described by Knapp in 1869 in a patient who had sustained blunt trauma. The first surgery was done over a century later in 1991 by Kelly and Wendell, who closed the macular hole after vitrectomy and membrane peeling, which has now come to be the standard practice. Idiopathic macular hole is the most common presentation. However, other risk factors include age, trauma, myopia, ocular inflammation, and cystoid macular edema. The prevalence of macular hole in India is 0.17%, and there is a high incidence in females. The mean age of presentation is 67 years. It has been theorized that macular hole formation may be due to trauma, foveal degeneration, vitreous traction, anterior-posterior transvitreous traction caused by vitreous fibers on the fovea extending to the vitreous base leads to the formation of a macular hole. Tangential traction, a theory proposed by Gass in 1988, postulated that tangential traction of the posterior cortical vitreous attached to the fovea resulted in central photoreceptor detachment and formation of a macular hole. Of the many surgical techniques described in the literature for macular hole repair, we present conventional ILM peeling, inverted ILM flap technique, and autologous ILM graft technique. We begin with a video recording showing conventional ILM peeling, a technique first described by Eckhart in 1997. A 61-year-old female presented with decreased vision in her right eye for over 1 year. At presentation, her visual acuity for distance and near were 2500 and N36 respectively. The optical coherence tomography showed the presence of a full thickness macular hole. To close the macular hole, pars plana vitrectomy, internal limiting membrane peeling, and gas tamponade were done. At the outset, 23 gauge sclerotomies were made. Anterior and core vitrectomy were performed. Posterior vitreous detachment was induced using a vitrectomy cutter with triamcinolone assistance to ensure complete cortical vitreous separation. After fluid air exchange, ILM was stained using 0.05% brilliant blue-green dye and peeled for about 2 disc diameters around the macular hole. (12% perfluoropropane was used as a tamponade. The 1-month post-operative OCT showed type 1 closure of macular hole with 20 micron central foveal thickness, and there was an improvement in visual acuity to 2200 for distance and N24 for near. Next, we highlight the inverted ILM flap technique for macular hole repair in a 59-year-old female who presented with decreased vision in her right eye since 2 years. At presentation, her best corrected visual acuity for distance was 2800 and N36 for near. She was diagnosed with nuclear sclerosis grade 3 cataract with macular hole. The OCT revealed the presence of a full thickness macular hole with base diameter of 1200 micron. We planned a cataract surgery with pars plana vitrectomy with inverted ILM flap and gas tamponade. After cataract surgery and 23 gauge pars plana vitrectomy with ILM staining, Eckhart forceps was used to peel the ILM 360 degree around the macular hole. Care was taken to ensure that the base of the ILM continued to remain attached to the edge of the hole. The ILM was then trimmed with the vitrectomy cutter and ILM flap was gently inverted over the macular hole. This was followed by fluid air exchange and gas encephalation. 1 month post-operatively, the patient's vision improved to 20/80 and N18. The OCT showed type 1 closure of macular hole. Finally, we present the technique of autologous ILM grafting. A 52-year-old pseudophakic female patient presented with decreased vision in her left eye for 18 months. At presentation, her best corrected visual acuity for distance and near were 23/20 and N36 respectively. The OCT revealed presence of full thickness macular hole and the pre-operative macular hole measured 1100 microns. The ILM flap was harvested and tucked gently into the macular hole. This was followed by careful fluid air exchange and gas tamponade. Post-operatively, the vision improved to 20/100 and the OCT showed type 1 macular hole closure with 220 micron central foveal thickness. To conclude, our video has highlighted 3 approaches to macular hole repair, including conventional ILM peeling, inverted ILM flap technique, and autologous ILM grafting technique. We have presented here the surgical pearls which a vitreoretinal surgeon should keep in mind when preparing for a macular hole surgery.